Hi, good evening and welcome everyone to tonight's presentation. This is Cancer and You, Let's Talk About Prevention. We appreciate that you're here with us and we're looking forward to sharing with you about cancer and how you can reduce your risk. I'm your host, Stephanie Nichols, Oncology Marketing Director at Franciscan Health. I'm excited for one of our physicians to share some great information with you as a part of our cancer education webinar series. This evening, with the help of one of our experts, we'll help you better understand what factors you can control to help prevent cancer, the importance of cancer screenings, and why knowing your family history is beneficial when it comes to cancer. Before we get started, I'd like to share a few housekeeping items. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. If you have any questions to ask the presenter, please click the Q&A icon at the bottom of your screen. You can privately type your questions in this window and we'll be answering at the end of the webinar. If you have a personal question that is specific to your own medical history, please note that we may reply to you after the webinar is over by phone or email to protect your privacy. Our awesome administrator, Kirsten, is taking care of everything on the back end this evening. If you experience any technical issues, just type them in the chat window and we'll work to resolve them as quickly as possible. If you miss anything, no need to worry. We'll send the recording of tonight's presentation to you in a follow-up email. Now let's get things started with a quick poll question to see why you decided to join us this evening. We'll have several poll questions throughout the webinar to keep you engaged. So let us know what sparked your interest in attending this webinar. Your choices are: A, I consider myself healthy and want to stay ahead of cancer by learning about screening and prevention recommendations. B, I have friends and family who have faced cancer and I want to educate myself on strategies to reduce my chances of getting cancer. Or C, I'm curious to learn more about the importance of various screenings, including when I get to each one. Take a few minutes to answer that question. All right, well, it looks like there's a little mix of everything, and a lot of people either have friends and family who have faced cancer or they're curious to learn about the importance of the different screenings and prevention. So there's a good mix here, and we're happy that you're here and ready to learn more about cancer prevention and how you can take control of your health. Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. I'm excited to introduce to you one of them who will be leading tonight's session. Dr. Nibal Saad is a medical oncologist with Franciscan Health Cancer Center. Dr. Saad received his doctorate in medicine from the Al-Baath University College of Medicine in Syria. He completed a residency in internal medicine at St. John Hospital and Medical Center in Michigan. He also completed a fellowship in hematology and oncology at SUNY Upstate Medical University in New York. Dr. Saad is board certified in hematology, medical oncology, and internal medicine. His clinical interests include medical oncology, benign hematology, and clinical trials. And now we welcome Dr. Saad.
Thank you so much, Stephanie. Thank you, everybody, for being with us today. And I'll go over our objectives, first of all, today. So today we'll talk about prevention. How can we prevent dealing with cancer? How can we avoid having to deal with cancer issues? And then we will move to, well, what we can do if we face cancer. How can we deal with it? And how can we catch it early so we can cure it? And that's where screening comes to play. Or, in other words, it is secondary prevention. And then at the last, we'll talk about, well, hereditary cancer, what we need to know about them, and how we deal with it in terms of medical providers. In terms of the factors that actually increase risk of cancers, we can divide them into intrinsic factors and extrinsic factors. The extrinsic factors are things that are around us, like environmental factors, lifestyle, infections, viruses. And these are the factors that if we control, we decrease the chance of having cancer. There is, on the other hand, intrinsic factors that are inherited in our body, in our genes. And these are the factors that if we know of, we may be able to tailor our screening process to detect any cancer early, and probably maybe do some surgical intervention or medical management that decrease the chance of cancer as well. So in terms of preventing cancer, we'll talk about things we can do, including smoking cessation, diet and physical activity, alcohol consumption limitation, weight management, skin health and sun safety, HP virus, and cancer prevention. So for smoking, smoking actually is one of the leading causes for cancer in the country, including lung cancer, bladder cancer, head and neck cancers, and other cancers. It's almost 48%, almost 50% of cancers death in the United States are related in a way or other to smoking. We know that nicotine addiction is difficult, but cessation is possible still, So it's very important to stress that fact. I would like to add two things here related to smoking, and that include e-cigarettes smoking and marijuana smoking. So e-cigarette smoking is controversial issue because even though it may help smokers to quit smoking, it may be easy step into smoking, especially for younger population. And CDC recommendations right now not to use e-cigarettes or vaping products containing THC, or any e-cigarettes or vaping products containing from informal sources. There are reports concerning the fact that there is chemicals that may be responsible for cancer in these e-cigarettes. So it's still not encouraged, but maybe it's better than smoking. It's not good though. Now, in terms of marijuana, there is no connection between marijuana smoking and respiratory cancers. There are a few reports, however, about the relationship between marijuana and testicular cancers. More to come down the road, but again, marijuana is not responsible for lung cancer. I want to stress that it's never late to quit smoking. Even, I talk to my patients who have lung cancer, even after diagnosis, it is beneficial to quit smoking. Now, we don't want to get there, so I want to prevent it. And at the time you quit smoking, compared to somebody who keeps smoking, actually the risk of cancer decreases. It takes many years to get the risk completely low to the average risk, but still decrease the risk of cancer right away. There are many ways we can help cancer or smoking cessation, and that includes behavioral therapy as well as medical therapies. In terms of the behavioral therapies and the programs that are available, we have a Aspire program at Franciscan Health, which is a smoking cessation program that we can refer our patients to. The other phone number we can get help from is 1-800-QUIT-NOW, which is a state-free telephone quit line support. In terms of pharmacotherapy or medications, we use nicotine replacement therapy, and that can be long-acting nicotine replacement therapy like patches, and that helps actually to decrease the need to get nicotine into the bloodstream. However, sometimes to take care of the urge to get that hit of nicotine, we recommend lozenges or gums, and that is helpful. Other medications we use includes varenicline or Chantix. It may cause some nightmares or depression issues, and discussion with the family doctor is important before starting these medications. The other medicine is Wellbutrin or bupropion, and it's antidepressant medicine that helps with smoking cessation. These drugs are helpful. It's more helpful when it's combined with cessation therapy or combined with physical therapy and intervention.
All right, thank you, Dr. Saad. We're going to pause for a quick poll question. Let's test our participants' knowledge on the topic of smoking. Please answer the following: true or false? Smoking contributes to nearly half of all cancer deaths in the US. True or false? Wait just a moment. Okay. 100% chose true. If you answered true, then you are correct. Nearly half of all cancer deaths in the US are related to cigarette smoking, about 48%, as Dr. Saad said. There are a lot of great resources available to help you or your loved ones quit smoking. So you can visit also franciscanhealth.org/aspire, ASPIRE, to learn more about our smoking cessation program that Franciscan has. Now we'll continue on our presentation with some of the information on how diet can affect our cancer risk and what you should know.
Thank you. So the other thing I want to talk about is diet. There is strong evidence that diet contributes to cancer incidence. Diets heavy in red meat, processed meat, are connected to colon cancer. Low fiber diet increased risk of colon cancer. Low fat diet, on the other hand, low in red meat, high in fruit, high in vegetables, actually may be protective of colon cancer. The Mediterranean diet is really encouraged, and it is balanced diet where lower amount of red meat, lower amount of fat and carbs, and higher amount of vegetables and fruits are used. I want to add, in terms of diet, a few things or statements about supplements. Vitamins, everybody or a lot of people ask about vitamins. There is no evidence that added vitamins, prevent cancers. The dietary supplements are not recommended for cancer prevention. And for patients who are diagnosed with cancer who already on supplement, we typically recommend to stop it unless there is certain deficiencies that we are replacing, because these supplements may interact with the cancer treatments or the chemotherapies. Physical activity is another thing that may help us to prevent or decrease the chance of cancers. Sedentary lifestyle is associated with increased cancer risk. Probably 25% of US population are living sedentary lifestyle, and that may contribute to about 5% of cancer. Routine exercises like 30 minutes a day, 3 to 4 hours a week in average, are very helpful to decrease chronic diseases and cancers. Multiple studies have shown that physical activity reduces the risk of colorectal cancer and postmenopausal female breast and endometrial cancer. That's for prevention, for somebody who never had cancer. Now, for people who already have colon cancer or endometrial cancer, actually, physical activity decreases the chance of cancer recurrence or developing new cancer. So I cannot stress enough the importance of physical activity. Alcohol consumption. Alcohol is responsible for many types of cancers, including liver cancer, colorectal cancer, breast cancer, oral cavity, esophageal cancer, and the risk of esophageal cancer, for example, and oral cavity cancer increases when the person who drinks, smokes as well. So that's why we recommend to limit alcohol consumption. For people who never had drinking problems, limiting alcohol consumption to 1 drink a day is recommended. Not more than 3 drinks binging at a time is kind of acceptable. For patients who have drinking problems, drinking is supposed to be off the table. Alcohol abstinence is recommended. One thing you need to know about alcohol cessation and quitting drinking. The withdrawal may be tough, and patient has to speak with the family doctor about quitting because withdrawal symptoms needs careful management by the family doctor, and some patients may need medications for that. Obesity is another risk factor that predisposed to cancer. Obesity is defined by BMI more than 30. Now, what's BMI? BMI is body mass index, and it is the result of dividing the body mass or weight in kilograms divided by the height in meter square. It is a risk factor for multiple types of cancer, including esophageal cancer, pancreatic cancer, colorectal cancer, endometrial cancer, postmenopausal breast cancer. And weight loss have shown to decrease that risk. There is a study in Women's Health Initiative where they followed 37,000 postmenopausal women, where intentional weight loss was associated with reduced risk of endometrial cancer. That showed actually almost 30% lower risk of developing endometrial cancer. And patients who had gained weight actually has higher risk of endometrial cancer. It doesn't matter how you lose weight. Bariatric surgery, physical activities, exercises, weight loss helps. And actually, bariatric surgery weight loss shown to be beneficial to decrease risk of cancer. We'll talk a little bit about skin health and sun safety. UV exposure from sunlight or from tanning booths actually increases the risk of one of the devastating skin cancers called melanoma. Melanoma incidence have been increasing over the last few decades. And the ways we can prevent that by limiting these ultraviolet tanning booth exposure, sun exposure, using SPF 30 sunscreen when you are in the sun, in the sunlight, and try to wear long sleeves hats, especially for people who spend lots of hours in the sun. There are a few things or medications that we can use to prevent cancer. There are medications like tamoxifen, raloxifene, aromatase inhibitors, which these medications work against the estrogen, which is the female hormone that is linked to breast cancer. So using these medications may decrease the risk of dealing with breast cancer. Aspirin was found to have positive effect to decrease risk of colon cancer. With low doses, baby aspirin between 75 and 100 milligrams is beneficial. And it is recommended for patients between 50 and 59 years old. Now, older than that, like patients 60 to 69 years old, may have some side effects from aspirin, like bleeding, which may be up to 60%. So we have to weigh the risks and benefits of that option also. Treating some infections like H. pylori infection in the stomach can decrease the chance of having adenocarcinoma or specific type of cancer in the stomach also. Other cancer preventing agents include HPV vaccination that decreases the risk of cervical, anal, vulvar, penile cancers. And it may also decrease chance of having head and neck cancers. CDC recommends 2 doses schedule of 9-valent HPV vaccine with 6 months apart doses, between 6 to 12 months apart doses for children and adults between 9 and 26 years. Here's wonderful. The other question.
Yes, wonderful. Sounds like when it comes to cancer and prevention, there's so many things we can do to help lower our risk. Let's ask our audience another poll question. Which of the following statements is true? A, heavy alcohol use increases the risk of head and neck cancers, especially when combined with smoking. B, dietary supplements are recommended in the prevention of cancers. And C, for safety, when using tanning beds, it's advised to use a sunscreen with an SPF of 30 or greater. All right, give everyone a few more minutes. All right, let's see what our responses are. Okay, 100% shows A. Our heavy alcohol use increase of risk in head and neck cancer, and that answer is correct. Thank you for answering our poll questions. We'll turn it back over to you, Dr. Saad, now to hear about cancer screenings.
So now we'll move to cancer screening. How can we catch it early so we can cure it? Mammogram save lives. So I cannot stress that enough. Mammogram, colonoscopy, pelvic exam save lives. So keep it in mind. Now, the introduction of mammographic screening in the United Kingdom in 1991 for women aged 49 to 64 years has led to overall reduction in breast cancer mortality. of 21%. That means among 100 patients who were screened, they saved 20 of them. They saved the life of 20 patients. That is great. The USPSTF recommendations. Now, USPSTF stands for US Preventive Service Task Force. They recommend mammographic screening every 2 to 3 years for average risk women between age 50 and 74. Now, for females between 40 and 50 years old, it's controversial and needs discussion with their primary care physician because the sensitivity is less, the breast is more dense, and there is high risk of complications of these procedures. So the benefit may be there, but there is slight increased risk of complications also. MRI may be recommended in certain population, like BRCA positive patients. BRCA is a gene that if it's there, it increases risk of having breast cancer. Cervical cancer screening. The Pap smear, which is a pelvic exam with swab that they take sample of the cells of the cervix and examine it under the microscope to see if there is any abnormal cells. And that helps to prevent cancer with very good sensitivity and specificity. Now, we learned afterward that actually having HP virus infection in the cervix is the main reason for cervical cancer. So detecting that viral infection may help us to catch the cancer early with improved sensitivity and specificity over the Pap smear. USPSTF screening recommendations are for females aged 30 to 64. Recommendations are either cervical cytology, which is Pap smear every 3 years, or HPV DNA molecular testing once every 5 years, or combination of those every 5 years. Now, for younger females aged 21 to 29 years old, Pap smear every 3 years is recommended. The viral test is not recommended because these viral infections may be transient and may not turn into cancer. So that's something we need to know. Colon cancer screening, save lives. So types of screening for colon cancer include fecal occult blood test, and that is a kit test that detects hemoglobin in the blood, hemoglobin in the stool, and it reduced the mortality between 15 to 33%. Again, when we say that, we mean among 100 patients who do these tests annually, we save 15 to 33 lives. It is huge. For the other type of test, fecal immunochemical test, it detects hemoglobin of human hemoglobin in the stool, and it's a little bit more specific. The other stool test includes multi-targeted stool detection test, which combines fecal immunochemical test, or FIT, with multiplexed methylated DNA. That's what everybody knows with Cologuard. It has higher sensitivity also. Now, in terms of invasive procedures, there's the flexible sigmoidoscopy, where the procedure is doing scope of the left side of the colon, and that helps to decrease mortality. However, it does not look at the right side of the colon. And that's when we do colonoscopy, where actually it looks at the whole colon with the scope. And then there is a way to do CT scan called CT colonography. And it's less invasive and can detect polyps that measure about 10 millimeters. So what are the recommendations for screening? We can do either annual fecal occult blood or stool test, or FET with DNA every 1 to 3 years. The other option is to do flexible sigmoidoscopy once every 5 years with the fecal test. Other option is to do colonoscopy every 10 years. The last option is to do CT colonography every 5 years. Now, the age of starting screening is 45 years now. It's not 50 as it used to be. It's recommended to start at earlier age at 45. Now, remember, this is for average risk population. If somebody has family member with colon cancer at younger age, they are recommended to start screening 10 years younger that age. For example, somebody, I have, somebody asking me, well, my dad has colon cancer at age 55, or say 50. When should I start colon cancer screening? It should start at 40 years old in that case, 10 years younger than the age of the diagnosis in the relative. Other situations where we have to start earlier are, patients who have genetic risk factors, or patients who have higher risk because of inflammation like ulcerative colitis and things like that. Lung cancer screening. The National Lung Cancer Screening Trial reported that low-dose spiral CT scan reduces lung cancer mortality by 20%. Again, that means if we screen 100 patients annually, we save 20 lives. Now, what is the recommendations to screen? Annual low-dose CT scan for people 55 to 74 years old. These patients should be current smoker or have quit smoking about 15 years earlier. Have at least 20-pack year smoking history. Well, what does that mean, 20-pack year smoking history? It is the result of multiplying the number of packs a day by the number of years of smoking. In terms of prostate screening, it's not straightforward. It's still controversial. And the reason is that even though PSA, which is the blood test we do for the prostate, is helpful to detect early cancer, it may lead to a lot of procedures and biopsies, which may cause complications like bleeding, like hospitalizations or infections and pain. So we have to balance the risks and benefits of such procedure. And it's recommended to have discussion with the family doctor before proceeding with such procedure for men aged 55 to 69 years old. Few things about melanoma, even though there is no recommendations to do screening for melanoma, but everybody should know these ABCDE acronym. So A starts for asymmetry. If there is a mole that is asymmetrical, it is concerning. B stands for borders. Irregular borders, jagged edges are concerning. C for color. Mole with different colors is concerning. Diameter. If it's more than 6 millimeters, which is the size of the pencil eraser. Or evolution, which means if there is a change in size, border, color, or diameter, it is concerning. Bring it to the attention of your family doctor. Please remember the acronym ABCDE for melanoma. Now the poll question.
Yep, there are certainly so many screenings to be aware of, Dr. Saad. As you mentioned, age is a factor for many screenings. We're going to have one last poll question to test our audience on what you've said. So let's take a moment and decide, is this true or false? The American Cancer Society recommends Americans of average risk receive their first colonoscopy at age 50. True or false? All right, let's see what everyone said. 100% said false, and that is correct. As Dr. Saad mentioned, the age for a first screening colonoscopy has recently been lowered to age 45. Please be sure to get your colonoscopy scheduled, and remember that in most cases, you only need a screening colonoscopy every 10 years if you've had no findings. Next, Dr. Saad will share on the topic of family history and how that may affect your cancer risk.
Now, the last part of our discussion today will be about hereditary cancer, cancer risk assessment, and when we consider genetic consultation or genetic testing. So there are multiple hereditary cancers that affect our risk of cancer, and they are related to germline mutations. When we say germline mutations, we mean mutations that are inherited through the bloodline, which are different from cancer mutations that happens and not necessarily always hereditary. Most common known germline mutations or hereditary mutations include BRCA1 and BRCA2, Lynch syndrome or hereditary non-polyposis colon cancer, and familial adenomatous polyposis. So BRCA1 and BRCA2 are responsible for having breast cancer, ovarian cancer, bladder cancer, pancreatic cancer, prostate cancer, mainly. Lynch syndrome, mainly colon cancer, uterine cancer, bladder cancer, and others. FAP or familial adenomatous polyposis responsible for mainly colon cancer. Now, things that everybody should know, and the red flags that everybody should know, includes early age at diagnosis. So if there is family history or personal history of early age at diagnosis of cancer, that is red flag to consider genetic testing. Multiple primary cancer, somebody who has ovarian cancer and breast cancer, somebody who has 2 breast cancers, it is red flag. Multiple individual with related cancers in multiple generations, somebody who has aunt, mom, and grandmother with breast cancer, or grandfather with prostate cancer, and father with prostate cancer, and another uncle with prostate cancer, it's concerning, and that is red flag. There are unique features of the cancers that may be red flags, like patients who had hundreds of polyps in the colon. That is concerning for FAP syndrome. Pigmented spots on the mouth or on the lips with polyps, certain type of polyps, that is concerning for certain syndrome called Putz-Jeghers syndrome. Certain dermatologic features like sebaceous adenoma, which is about 1 centimeter yellow, whitish colored nodule under the skin, associated with certain type of Lynch syndrome, and it may be associated with colon cancers. Certain histologies like triple negative breast cancer also is a risk factor to have genetic abnormality. Certain ancestry like Ashkenazi have higher chance to having BRCA1 and BRCA2 mutations. So everybody should know something about this, including these red flags. Now, on our end as healthcare providers, we look at it in terms of estimating the risk and then what we can do to decrease that risk. Sorry. So risk assessment include using personal history. Was there any personal history of cancer or precancerous lesions, history of screening for cancer, history of vaccinations, about family history, ancestry and ethnicity, like we mentioned about Ashkenazi, pedigree, which is diagram where we actually plot all the relatives and who was involved with cancer diagnosis and what type of these cancer and what age was the cancer diagnosed. Cancer characteristics, as we mentioned, especially for breast cancer and triple negative. There are models that we can use to estimate the risk of cancer development, like breast cancer risk model, Gale model, Close model, Tarasuzic model, and they are kind of formulas. We don't try to remember them, but they basically look at the years of starting menstrual period, exposure to estrogen, multiple pregnancies, family history, and come up with score that give us kind of the risk of developing breast cancer over lifetime or over 5 years. There are other models that we can use to evaluate the risk of having BRCA mutation or Lynch syndrome. And based on all this information, we evaluate the benefits or outcome of this genetic testing. So bottom line, should I consider genetic testing? The answer lays in first, is there any red flags? And then, based on the final assessment that we have mentioned above or previously, should we send the patient to a genetic counselor? If there is high risk based on the models we mentioned, if there is red flags, we have the patient meet with our genetic counselor, or we have the discussion with the patient about the risks and benefits of getting these genetic testing. Remember, it has a lot of anxiety with it. There is sometimes financial issues with it, obligations to tell another family members, and all what comes with this knowledge. It may help to screen cancer better, but there is some downside to it, and that needs to be discussed. And the limitation to these genetic testing, because sometimes we find about genes that we really don't know how much they may play a role in cancer. So we have to discuss all these issues before we do the test and conclude it. I will finish my presentation with this quote to Sun Tzu from The Art of War. The supreme art of war is to subdue the enemy without fighting. Thank you for listening, and I'll be happy to answer any questions that may be there.
Thank you so much, Dr. Saad. That was so much vital information, and I know we could have spent a lot more time on each of those topics you touched on. At this time, let's begin our question and answer session. We've gotten some good questions sent through the chat, so let's dive into those and see what the audience is interested in hearing more about. If you want to ask a question on the chat box, as we mentioned at the beginning of the seminar, you can type in your question there, and then we will answer that. So let's get started. Looks like we've got one here. Do I need to have symptoms to get a cancer screening?
So, no. The cancer screening is for people who have no symptoms. Whenever there is symptoms, it's not screening anymore, actually. It is diagnostic. I get that a lot. Somebody who tells me, well, my doctor told me, somebody who's like 75 years old who has iron deficiency anemia. And I tell them, well, you need to do colon cancer. They say, well, my doctor told me that I don't need it anymore because of my age. That is diagnostic test to detect why there is blood in the stool. It's not screening test. So the short answer is that we don't need symptoms to do the screening.
Okay. How about, do I need a referral from my primary care physician for most of the screenings you talked about?
Not really, especially for mammogram, and I think for the CT scan also. Now, for colonoscopy screening, I think you can call the colorectal surgeon or the GI doctors, and they can communicate with the family doctor to get the referral or the order for that.
Okay, wonderful. A few more. What is the advantage of a colonoscopy over other tests like Cologuard? I know there isn't any prep with Cologuard, so I'm not sure which is better to do.
Right. So, the Cologuard is easy, right? It's convenient. You don't need the prep. You don't need to go anywhere. You just do the test. And it's, on the other hand, if it's positive, then you will need colonoscopy. So the colonoscopy, first of all, it's less often, and it's the pros of it. It actually, when you do it, they can take the biopsy and give you the diagnosis right away. The cons, though, it's just invasive procedure. So that's how we look at it. Eventually, if there is positive results of the fecal occult blood or the guaiac test, you end up with needing also the colonoscopy. It's acceptable to do either or though.
Okay, wonderful. Another one. What is your opinion on genetic testing like 23andMe or Ancestry?
It's interesting. I think if it's not financially problematic, I think it's not gonna hurt. However, the problem with it is there are a lot of genes that we really don't know what to do with. what to make out of. But it does not hurt if you are ready to hear what they have to say. And then if there is positive results, then I think you can discuss that with your family doctor, and then talk maybe to a genetic counselor and confirm with officially more reliable, comprehensive germline genetic testing. So I think it's okay. Just you have to understand that, well, if there is positive results, will that make your life harder in any way or not? And is it gonna help you in any way or not?
Okay. So what happens if a screening test shows something suspicious? Would I automatically need to see an oncologist?
Yes. So oncologist or somebody who takes care of the cancer. For example, if there is positive mammogram, you either need to see oncologist or breast surgeon who takes care of breast cancer. Or if there is a lung nodule on the CT scan, well, you either see oncologist or pulmonologist who takes care of diagnosis of lung cancer. So yes, you need referral to take care of that issue.
Okay. There's one on smoking. I grew up in a house where my parents smoked, but I didn't smoke. Should I consider a lung scan because of all the secondhand smoke?
Very good question. Remember, you have to meet certain criteria to qualify for that cancer screening. So even somebody who actually was smoking, but not that long or not that much, they don't meet the criteria to qualify for that screening. And you may ask, well, why not? The reason is that it is expensive, it's costly, and you have to screen a lot of patients to get diagnosis. And sometimes there is false positivity, meaning there is nodule that is not cancerous. And that leads to anxiety, to procedures, biopsies, or bronchoscopies that otherwise not necessary. So short answer is that not really, because there are certain criteria we have to meet to qualify for this screening.
Okay. Another one is you talked about alcohol and its increase for cancer, different types of cancer. What actually happens when you have alcohol, and how does that determine you have cancer or is a risk for cancer?
So alcohol consumption increases risks of multiple cancers. Typically, when people drink alcohol and for a long time, that may irritate the esophageal lining, which is the food tube that goes to the stomach. So irritating that area may cause cancer eventually, especially for people who smokes. In different type of cancers, like liver cancer, alcoholism cause cirrhosis that end up with liver cancer also. Other correlations, for example, for breast cancer. Now, breast cancer is very common. So if there is any slight risk related to alcoholism, that actually increased slightly the risk of breast cancer. I think it increased about 12% over average population. So that's how that comes to play in terms of the role of alcoholism in cancer development.
Okay, I think there's just a few more. And then this one is, I chewed tobacco for about 15 years, but stopped over 10 years ago. I worry about oral cancer from years of chewing. Should I be worried? And what should I be looking for?
Yes, and typically, when you check with your family doctor, oral exam is recommended on annual basis for anybody who smokes, even cigarettes. And it's more so if you've been chewing tobacco, and the dentist actually. So these are the two people who look into the mouth and can detect any early issues. Now, if there is any ulcers or nodules, please, bring it to the attention of your primary care physician or dentist, and take it from there.
Okay, and we can have a few more questions. So if people want to continue to put them in the chat box. One is I've heard about Zoloft for smoking cessation. Do you have an opinion on that?
Zoloft is not really used for that, and there are some antidepressant medications that are used, like Wellbutrin or Chantix. But Zoloft itself, I've never used it, or I don't think it's used for that specific indication though.
Okay. What are the risks of cancer in eating fast food?
So fast food, when we talk about fast food, we are talking about high fat, low fiber, with a lot of processed meat. And these are the things that actually increase the colon cancer. These are the things that actually associated usually with bad diet, more overweight, and that will result in connection to other cancers like endometrial, as we spoke, like breast, especially for postmenopausal women, and for with obesity, esophageal cancer risk increases as well. So that's how the connections come to play.
Okay, are there any other questions? And if not, Dr. Saad, if there is one key takeaway to give to our audience on cancer prevention, what would that be?
Well, I wanna end it with this. Mammogram save lives. Colon cancer screening save lives. Pap smear and cervical cancer screening save lives. Please remember those things.
Thank you so much, Dr. Saad, for your time and your wealth of knowledge shared with us on this webinar. We appreciate your expertise, and I know everyone learned a great deal. If we didn't get your question tonight, we'll do our best to contact you using the phone number or email address you provided at registration. If you feel that you would like more information about our cancer risk or your cancer risk, a great place to start is by taking our online health risk assessment. We offer these assessments for lung cancer, colon cancer, breast cancer, and a variety of other health topics. Just visit franciscanhealth.org/answers to take your assessment. And it's in the chat box over there. And you'll receive a free email report that you can share with your primary care physician on your risk. These health assessments are not diagnostic, but they're a great starting point for conversations with your physician. If you've been encouraged tonight with Dr. Saad to get your recommended cancer screening, you can visit franciscanhealth.org/screenings. And we have a list of all those screenings he was mentioning on this site where you can learn more about them and make an appointment. We know that your time is valuable, so thank you again for joining us and making your health a priority. Once again, we'll send you an email with the recording of this session. Feel free to share with others who might find it helpful. You'll also receive a brief survey about this webinar and its content. Your feedback is truly important to us and will help make future seminars even better. So please take a few moments to fill out the survey. On behalf of everyone at Franciscan Health, thank you so much for being with us and have a blessed evening.
Thank you so much.
Thank you. Have a good night.
Have a good night.